Assalamu alaikum. Good evening, everyone. On behalf of the Saudi Society of Blood Disorder, I would like to welcome you to the fourth and the last best of 2021 ASCO and EHA webinar series on cellular and immunotherapy. Today, we have an eminent speaker from Saudi Arabia and from Kuwait. We will start our meeting with the presentation on the CAR T cell update from EHA and ASCO presented by Dr. Nawal Al-Shahri, who is the chairman of the Department of Hematology at King Fahd Medical City in Riyadh. Following that, we'll have a new presentation on the adult CAR T cell program at King Faisal Specialist Hospital, which is the first CAR T cell program in the region, on when to refer and how to refer patients and who are the candidates for CAR T program, presented by Dr. Saeed Osman from King Faisal Specialist Hospital. And then we'll have a discussion for 15 minutes. Following that, we will have a satellite symposium on the update of multiple myeloma presented by Dr. Anita from Kuwait Cancer Center. She's a hematologist at KCC. And then we will have the transplant, bone marrow transplant EHA and ASCO update presented by Dr. Osman Binyam, who is a consultant hematologist at King Faisal Specialist Hospital in Riyadh, in Jeddah. So without any further delay, please welcome with me Dr. Nawal Al-Shahri, who will speak about the CAR T program. Dr. Nawal, the floor is yours.
Okay, Assalamu alaikum wa rahmatullahi wa barakatuh jami'an. Good evening, everybody. Thank you, Dr. Ahmed, for the introduction. Welcome, dear guest, for this session sponsored by the SSPD. And thanks for giving us the opportunity to go over this very important topic, actually, which is considered as revolutionary therapeutic modality that introduced to the field of hematological malignancy since 2017. The topics that I will go over is the basic structure of CAR T cell, as well as we will go over the evolution in manufacturing CAR T cell, mentioning the difference between each generation of CAR T cell, mechanism of action of CAR T cell, and how we relay in CAR T cell in defeating cancer cell application, or the approved application so far for CAR T cell in hematological malignancy in view of EHA and ASCO, and brief touch on CAR T cell toxicity. So as you all know, that chimeric antigen receptor T cell therapy is a novel adaptive immunotherapy where simply T cell lymphocyte engineered with synthetic receptor. And the purpose is that the CAR T cell, the effector T cell, will eliminate the specific cancer cell, which is independent of immunohistocompatibility complex. Several antigens that are presenting by tumor cell have been targeted so far, and it's been used for treatment of BALL, cell lymphoma, and recently approved for multiple myeloma. By far, the most successful CAR T cell is the one directed against CD19. Several trials are going against myeloid malignancy expressing antigen, with no much proved evidence so far. So the structure of CAR T cell is composed of four main structure: the extracellular antigen binding domain, which is will bind to the specific target antigen expressed by the tumor cell. The spacer or the hinge, which will connect to the extracellular antigen binding domain through the transmembrane domain. And then we'll have the intracellular co-stimulatory domain, which will differ according to the generation of the CAR T cell, and the intracellular signaling domain. If we look into the structure of CAR T cell in more depth, the extracellular domain is basically called like the single chain variable fragment, which will have the affinity or very high affinity toward the target antigen expressed by the tumor cell. The transmembrane domain, mainly CD28, and then we will have the intracellular domain, the CD30. When we will come to the transmembrane domain as well as the signaling domain, it differed from one generation to different generation. If we look at the evolution of a structure of CAR T cell, the first generation started only with the single chain variable fragment and the intracellular domain plus the transmembrane domain. As the progress of manufacturing CAR T cell during the synthesis, they add the CD28, which is the co-stimulatory signaling. And then with the third generation, they add another co-stimulatory domain, which is the 4-1BB. The fourth generation and fifth generation depend on addition of other signaling domain for cytokine receptor, and all these modification in the different generation of CAR T cell actually aim to increase the efficacy and increase the survival of CAR T cell. How does the CAR T cell fight tumor cell? Through three important axes. Number one is by fighting antigen positive tumor cell, and this is through the release of granzyme and prion, and then through the stromal cell sensitization. And the third is through fighting the antigen negative tumor cell, in which the antigen is not expressed through the Fas ligand and the Fas protein. Manufacturing, very straightforward. The T cell extracted from the patient, and then it will go through the engineering process where the viral vector introduced to the T cell, the DNA material will be incorporated into the T cell, expressing into the expression of the surface markers. This will lead, then it will go through multiplication, and then we will prepare the patient for CAR T cell through what we call conditioning or lymphodepletion, and then the CAR T cell will be reinfused to the patient, and then they will go through monitoring process or observation. Application of CAR T cell in hematological malignancy, by far as in the update in the ASCO and EHA, this summarize all the FDA approved CAR T cell product based on the indication. And we can see, as we all remember, in August 2017, we get the first approval for Tegicel, which is an anti-CD19 for the treatment initially for pediatric patient in second relapse or later in the acute lymphoblastic leukemia. Later on in 2018, the same product was approved for relapsed refractory large B-cell lymphoma in patients who failed more than 2 lines of chemotherapy, as well as aggressive or high-grade B-cell lymphoma and diffuse large B-cell lymphoma arising from follicular lymphoma. As you can see, the infusion dose is different according to the disease. The lymphodepletion protocol could be Flu/Cy or bendamustine, and these are the 2 pivotal trials based on which the approval was guaranteed. Later on in October 2017, Axicel was approved for the treatment of relapsed refractory diffuse large B-cell lymphoma. Again, it's anti-CD19 directed CAR T cell. This is the infusion dose, 2 × 10⁶ per kg, up to 2 × 10⁸ cell per kg. The lymphodepletion protocol is almost the same. And this is in ZUMA-1 trial approved in which the approval for diffuse large B-cell lymphoma. And later in 2021, recently, the ZUMA-5 trial published their result and led to the approval of the same CAR T cell agent in patients with relapsed refractory follicular lymphoma. In June 2020, Prexacel was approved, and this is a very recent approval actually for management of patients with relapsed refractory mantle cell lymphoma treated with up to 5 previous lines of therapy. Again, it's anti-CD19. This is the infusion dose and the lymphodepletion protocol. This is the ZUMA-2 trial. And then the Lysocell was for the approval again for aggressive B-cell lymphoma. And lately, we have the approval of Idocel for treatment of management of multiple myeloma in KarMMa trial. So as we're focusing on highlight in management of CAR T-cell, I will start with the recently approved indication in multiple myeloma. So ide-cel is a CAR T-cell manufactured product that target B-cell maturation antigen, and it has shown clinical activity and efficacy in multiple myeloma, relapsed, refractory, and also patients who have been heavily pretreated with reasonable and expected tolerable toxicity. So KarMMa clinical trial is a single-arm phase 2 study that confirmed the efficacy and safety in patients with relapsed and refractory multiple myeloma. Patients with the disease after at least 3 previous regimens, including failure of proteasome inhibitor, immunomodulatory agent, and anti-CD38 were also enrolled. Patients received ide-cel target dose ranging from 150 times 10 to the power 6 per kg, and then 300 or 450. The primary endpoint was overall response rate, and the secondary endpoint was complete response or better. And if we look at their result, total patients were infused around 73, 26 of them receive total patient infused 128. The 26% of them achieved complete response or stringent response with negative MRD. 7 achieved complete response or stringent response, but MRD could not be detected. 20 achieved very good partial, and 21 achieved partial response. And if we look at that, they did subdivision according to the dose infused, 150 or 300 or 450. And considering that those patients are heavily pretreated in multiple myeloma, this is considered a very encouraging result. Another thing is that in their subgroup analysis, most of patients benefit actually and showed a reasonable response, regardless of their age or the number of line of treatment, whether it's triple refractory or extramedullary disease or bridging therapy. And if we look at their survival curve, starting by, they did subdivision according to the CAR T-cell infused, and regardless of the dose, although the high dose 450 showed some superiority earlier, but again, after 12 months, almost of them, they have the same overall duration of response. Again, their curve according to the type of response, almost most of them, if we look at the subgroup, they achieve around 19 months. Overall, the progression-free survival also for the subgroup were comparable after 12 months, and the overall survival was around median 19.4 months. So talking about ide-cel in patient multiple myeloma who have been heavily pretreated, it has shown that it induced a good response, achieving MRD negativity in 26 of patients, and almost some patients they develop some grade 3 or 4 toxicity, which are associated with CAR T-cell. Point that we learned from the study is like achieving 19-month treatment-free remission for patients with multiple myeloma who are heavily pretreated is something really considerable, considered as really encouraging. And this raised few questions whether early introduction of CAR T-cell in less advanced disease will have a better role, as well as if this is what we got with single infusion of CAR T-cell in those patients, whether there is any rule of retreatment or reinfusion plus or minus maintenance therapy in those patients. Again, then after that, we have the approval of CAR T-cell in mantle cell lymphoma. And as we all know, the ZUMA trial published the result, which is a multi-center phase 2 trial. ZUMA 2 used the KIT X19, which is also known as Praxicel, to evaluate the patient with relapsed refractory mantle cell lymphoma. As we all know, that patient who failed multiple line chemotherapy as well as BTK inhibition usually associated with poor prognosis, and given the previous success of CD19-based CAR T cell, this raised the possibility that why not to be treated, to be used in treatment for mantle cell lymphoma. So the primary endpoint was the percentage of patients with objective response, complete or partial, and this was assessed by separate committee according to the Lugano classification. And then the primary efficacy analysis was to be conducted after 60 patients had been treated and follow up for around 7 months. This is their result curves and figure, but before that, I would like to go over the patient characteristic, as they included most of the patients with high-risk feature, whether elderly more than 65, those with high Ki-67 proliferation index, TP53 mutation, failure of previous PTK inhibitor, whether ibrutinib or acalabrutinib, relapsed refractory disease with or without stem cell transplantation. And if we look at their result figures, 56 patients, around 93% infused with the CAR T cell, 40 of them, which is 67%, achieved complete response, where 27% achieved partial response. And if you look at the duration of response, it's considered very reasonable duration for patients who failed multiple line chemotherapy with almost durable duration, reaching more than actually 18 to 20 months. Interestingly, also in their subgroup analysis, patients with high-risk feature, those more than 65, patient with relapse after stem cell transplant, patient with high mantle cell lymphoma IPI, with high Ki-67, with P53 mutation, all of them, they benefit from the CAR T cell therapy. And they come to the conclusion that it induced durable remission in majority of patients who are relapsed and refractory, and therapy associated with some life-threatening toxicity, which, as we will come later on, which is expected with the CAR T cell. When we come to CAR T cell management or role in myeloid malignancy, we can see that we did not get that much success as we got in lymphoid malignancy. Several trials are being conducted from phase 1 to phase 3 in the States, Europe, and China. However, it's still challenging with no approved indication yet in treatment, whether AML or AML/MDS or even CML. And this is basically attributed that there is no truly leukemia-specific cell surface antigen, and most of the AML antigen are frequently shared by the normal hematopoietic stem cell. The manufacture of CAR T cell itself may be challenging in patients with active acute myeloid malignancy, and that's due to inhibition of T cell expression by AML blast or previous exposure of T cell damaging chemotherapy. Again, as we all know, AML is still heterogeneous and complex disease and can really escape the rule of CAR T cell through evading the immune system means by means of various immunosuppressive mechanisms. So CAR T cell therapy for AML is already in clinical trial, but we're still facing challenging and obstacle to ensure the effective and the safety of CAR T cell use in myeloid malignancy. When we come to CAR T cell toxicity, briefly, I'll go over the cytokine release syndrome, CAR T cell related neurological toxicity, encephalopathy, and lately termed as immune effector cell associated syndrome, tumor lysis syndrome, as well as cytopenia. For the sake of the time, I'll just go. We all know the incidence of cytokine release syndrome differ according to the type of CAR T cell use as well as the type of disease. The more the disease burden, the more the risk of cytokine release syndrome. And the percentage or association with different CAR T cell cannot be really considered comparable because they were measured according to different scale published in their studies. Pathophysiology, simply CAR T cell recognize the tumor cell, and this will lead to macrophage activation, monocyte recruitment, cytokine release, and this will lead to chemokines production, vascular leak, and then the cytokine release syndrome. Grading system, we have multiple grading system, most commonly used is NCI as well as the ASBMT, and the symptoms are graded from grade 1 to 4, accordingly starting from grade 1 where there's no life-threatening or organ failure, and then it will progressively go down to grade 2 where you will still have some life-threatening manifestation, but it will be responding to moderate intervention, and then grade 3 and grade 4, you will go life-threatening complication with multi-organ failure. Management is mainly conservative for grade 1 and 2. When you go to grade 3 and 4, we'll start to use interleukin-6 inhibitor, which is the tocilizumab, can use single dose or repeatedly, and then systemic steroid is also being used. Central nervous system complication or CNS-related toxicity is very major complication or limitation for the CAR T cell, and it can be ranged from simple headache to convulsion, confusion. Basically, it is resulting from the inflammatory reaction that will lead to disruption of the blood-brain barrier and then inflammatory damage to the microglial cell and neural cell. No specific treatment, mostly conservative, systemic steroid. Again, the CNS toxicity is variable according to the disease and the therapeutic agent. What can we do for CAR T cell toxicity? It starts from prevention, early recognition, and also treatment-adapted modality. Pre-medication is very helpful, acetaminophen and diphenhydramine given 30 to 60 minutes prior to CAR T cell infusion. It's very important to note that prophylactic use of systemic steroid is contraindicated in CAR T cell, and that's because it will interfere with the activity of CAR T cell. That's why it is not recommended. Vital signs like temperature and other things should be monitored carefully prior and during, as well as post T cell CAR T cell infusion. Life-saving measure, oxygen, emergency drug equipment should be readily available. As we said, prevention, prompt recognition, and switch off of the CAR T cell effect. So prevention of CAR T cell related cytokine release syndrome and neurotoxicity, it can include risk-adapted therapy, where if you think the patient is having high tumor burden, sometimes they will go to reduction of the dose of CAR T cell. Cytokine release prophylaxis, it has been tested for tocilizumab, they can give some prophylactic dose. However, it did not prove to be efficient, especially in grade 3 and 4 toxicity. Prevention of on-target off-tumor effect, and that's we can do it by manufacturing selective antigen CAR T cell, deleting the target antigen on the normal cell, and optimizing the CAR T cell efficacy. Switch off in this suicidal gene, as we know, destruction of CAR T cell by monoclonal antibody. So in conclusion, the benefit of CAR T cell has been very well demonstrated and evidence-based in B-cell malignancy that express CD19 and recently in multiple myeloma. Still ongoing study in myeloid malignancy. Strategy to diminish the toxicity based on prevention and prompt recognition of severe adverse event are currently available for clinical use. Ongoing development of new generation CAR T cell will provide opportunity to increase the cure rate associated with CAR T cell while decreasing their toxicity. And I think I already passed the time, and with that I will conclude, and thank you very much.
Thank you so much, Dr. Nawal, for a nice illustrative presentation on the CAR-T program. And the next presentation will be by Dr. Saeed Osman. He will present an interesting topic on the program at King Faisal Specialist Hospital, first of its kind at the region in the Middle East, on the CAR-T cell therapy, when to refer our patients and how. Dr. Saeed Osman, the floor is yours.
Thank you very much, Dr. Ahmed. Thank you, Dr. Nawal and Dr. Amal, for inviting me and allowing me to talk about this. Can you see my slides? And can you hear me?
Yes, Dr. Osman, you can proceed.
Okay, thank you very much. Okay, so we thought when Dr. Amal had put the invite out that initially the suggestion was to talk about CAR-T toxicities, but I think Dr. Nawal has covered most of what needs to be covered in terms of CAR-T and toxicity. So we thought the most useful thing might be for attendees to get an idea of some of the practical steps of getting access to this care and how we can communicate better and quickly get patients to CAR-T cell therapy, certainly for those who need them. We had shared, certainly on social media and WhatsApp groups, this sort of little guide that we thought was really useful and perhaps maybe a bit overdue for our colleagues, as this being new for us and it's a learning curve for everybody. We thought it was important to just give people some tips of how to get patients to CAR-T as quickly as possible. In putting this document together, we mainly relied on the two studies, the registration trials, both for ALL and for NHL that are on the right of the screen, the New England Journal of Medicine papers, both for ALL and NHL. And there are a number of consensus documents that had been put together. The first one, I guess, was the ALL recommendations put together by Ankit Kansagra and Shahrukh Hashmi, which was the EBMT-ASBMT combined recommendations. There was a similar one for NHL by Tanya Jain and colleagues, and there was Ibrahim Yaqub Agha's et al.'s EBMT recommendations. Most of these are in sync with each other. There are a few differences between, say, what the EBMT might recommend and what the registration trials would have recommended, or what the inclusion-exclusion criteria were. And where that happens, we tend to go by the inclusion criteria of the trials. Now, this is, again, an overview of the commercial CAR-T process that had already been elucidated by Dr. Nawal Shehri. And we know that we collect CAR-T cells, certainly for Tissagene loose cell or Kymriah, which is available currently in King Faisal. So the patient gets apheresed, and then the cells get cryopreserved. This is unlike, say, the Yescarta product, where the cells aren't cryopreserved, but they're sent fresh to the manufacturing facility. The cryopreservation actually allows a bit of flexibility in ways that you can sometimes cryopreserve and hold, not actually send the product in a certain subset of patients. So, but to summarize, cells are collected, frozen, then shipped to a central manufacturing facility. And at the moment, the facility that is supplying us is the facility in New Jersey, Morris Plains. So it does take a bit of time to get there and to get back, more than about 24 to 36 hours, because there's 2 stops on the way. It gets produced over there, and we can track from Riyadh, can track what's happened to the cells, at what stage of processing they're at. Then they get cryopreserved after being produced. They get sent back, and as soon as the cells arrive and we have them in hand, we try to get the patient in for lymphodepletion. But all in all, you're talking about 21 to 28 days, more closer to 28 days, vein to vein. But remember, there's some preparation that needs to happen before that. So if I can, sorry, yeah, here we go. So there's certain considerations for the referring physician when they refer the patient. Obviously, the first one is that the patient has a licensed indication for CAR-T therapy. And we know, especially for NHL, the label or the license indication varies slightly between the different products. So, for example, Yescarta may allow treatment for primary mediastinal B-cell lymphoma, whereas Kymriah doesn't. Lysocell, likewise, has a slight difference. So, and there are certain other subsets that were excluded from trials, such as T-cell rich B-cell lymphoma, which was not included in the Kymriah trials. So the most important thing is to make sure that the pathologist's diagnosis matches the labeled indications for which we're allowed to give Kymriah. The other thing then is the patient. Is the patient fit? So, for example, if a patient's performance status is 4, or they have multiple organs that are dysfunctional, then that probably won't be the best candidate for CAR-T therapy. And then there are a number of other considerations. Now we look at see the timeline that you're talking about, 6 weeks on average from first visit to infusion, at least. So one of the considerations there is in very aggressive disease or in very bulky disease, can this patient actually wait for CAR-T cell therapy, or should they get something else? Now we know from a lot of the data that CAR-T cell may not be the best therapy for especially in the case of NHL, but also to a certain extent in ALL, it may not be the best therapy for rapidly progressive, highly proliferative disease, or cases with NHL with a very high LDH. So smaller bulk, a good performance status, that's the right sort of patient. So one, can the patient wait, or is this disease just too aggressive? And then 2 is patient fitness and organ function. So good performance status, renal function that's preserved, an echo that shows adequate cardiac function, because remember, a significant proportion of these patients might get CRS, and they must have the physiological reserve to be able to deal with hypotension and fluids, and you don't want them to end up in ICU. And then the other issue is the timing and type of salvage therapy. When talking about the toxicities now, in order to have a CAR-T program, the center has to go through a risk evaluation and mitigation strategy program, a REMS program, where everyone's been adequately trained, the unit's been trained, physicians have been trained off as to how to deal with CRS, how to deal with ICANS. The patient gets adequate information. We have an algorithm for CRS and ICANS that goes on the door of all patients who are having CAR-T, so that when the person on call comes, it's very clear as to what to do, what the grading is, and what to do for that grade. Also, the patient gets a card that they have to always have with them to say that they've had CAR-T therapy. So this is partly why we have to be very careful about the sort of patient that we select. The other point, which was about planning the bridging treatment or selecting the appropriate salvage therapy. If a patient gets a certain salvage therapy, especially, for example, bendamustine or other T-cell lytic agents, some of these need an 8 to 12 week washout period before you can put them on an apheresis machine to get the T cells. So if a patient has had bendamustine, then we're sort of stuck for 8 to 12 weeks. We can't apherese them. So the closest time they can get CAR-T cell therapy is 8 plus 4, 12 weeks or 14 weeks. So it might sometimes be an idea. In those cases, it's to sort of, we actually sometimes consider a backup pheresis. If the patient is going to get polar BR, for example, before we give the bendamustine, we would advocate collection of the cells and use the polar BR as a bridging therapy if the patient otherwise fulfills the criteria for CAR-T. So this is the rough timeline. So you have the workup. When we first see the patient, the workup roughly takes at least 2 weeks from the point of first seeing the patient to be able to collect them. We're trying our best to try to make this shorter, because then once you apherese them and you send the product off, you have 4 weeks in which you need to bridge them, during which time the cells are being manufactured centrally. Then the cells come back and you lymphodeplete and infuse the cells. So this is a very time-sensitive process, and it needs very close coordination between the physicians, the referring center, the coordinators, the vendor, and the stem cell lab, and other things that are outside our control, such as the customs and logistics. There were concerns during COVID whether we might be able to make this in time. So time is of the essence. So we will try as much as possible, if there is a referral, if there's any patient out there who needs CAR T, we would want to really see them within 5 working days. So even if you call the number that I'll show at the end of the slide, and we can try to even get a virtual consult, try to discuss the patient in our weekly MDT, so that we can plan for the patient's arrival. So as soon as they come, we can very quickly do the workup, very quickly collect cells. So we want referral to first visit within less than 1 week, and first visit to dispatch in less than 2 weeks. And this is what we have to go through. I'm not going to go through all of this, but this is, once the patient comes to us, this is the process we have to go through before the patient gets infused Kymriah. So it is very time sensitive. When the patient is getting referred, well, one tip is just to make very clear on top that this patient is being referred to King Faisal Specialist Hospital at Riyadh for CAR T-cell therapy, because there are central referral systems both within the ministry and within King Faisal. You just need to make sure that the referral gets to the right center, because sometimes it can get channeled into the wrong place. It's very helpful if the report has some important information about the patient's disease and fitness. And when the patient comes, it's best that they come at their first visit with the slides, with the blocks, and with the flow reports, especially if it's ALL, so that we can very quickly send it to the pathologist, because we do need central review. We need something on our system to say, this patient is fit for CAR T therapy. It's helpful just to tell the patient that they're going to go for some genetically modified therapy, just in case they say, well, we don't want any genetically modified therapy. If they have a portacath, it might be best to remove it, because we may not be able to move portacath inserted somewhere else. We have a weekly MDT, which is at 4:30 p.m. on a Sunday, and often colleagues around the country call us, and we actually get them to present the case in our MDT even before we see the patient. So we're prepared for the patient before we see them, and we try to get them into the first clinic that week. And generally, in order to proceed with CAR T, the majority of present physicians have to vote in favor. If a patient is seen, they've been screened, and they sign a consent, then they are formally considered to have been enrolled into the program. And it's important to note that a patient may be enrolled into the program, but for whatever reason, they may not receive CAR T cells, and that we would be familiar with this even from the studies. Not everybody who enters the trial actually got Kymriah or Yescarta, and likewise, not everybody who comes to us and signs a consent or even has cells collected will in the end get the cells. They might become sick, or their performance status may deteriorate, they might get an infection, might end up in ICU, or we may not be able to produce cells for them because of the quality of the T cells. So that is something they need to be aware of. For NHL, these are the diseases that are eligible: diffuse large B-cell lymphoma, high-grade lymphoma, NOS, and diffuse large B-cell arising from follicular lymphoma. So certain diseases weren't part of the trial, and it's not indicated for patients with primary CNS lymphoma. This is our algorithm, which again, we have shared in our document, and this was put together after a lot of consultation within the department and after expert review from external experts from the CAR T field, including, we were thankful to Mehdi Hamadani for having looked at this and some of the other experts. It does take into account that even in patients who achieve a CR after second salvage, then auto transplantation is still an important modality, and it, from the last blood paper from last week, may actually be superior to CAR T. For relapsed and refractory B-cell ALL, again, the patient must be either refractory, have failed 2 lines of therapy. They do need to have bone marrow disease, and most countries will not enter them into a program until they have bone marrow disease, though in exceptional circumstances, even despite less than 5% blasts, we do consider these, but anything outside of the ordinary, we often get a consult from an external expert, especially as this is our first year, we find that very helpful. It's important before starting a salvage therapy, especially blinatumomab or inotuzumab, just by all means touch base with any of us, and we can try to coordinate to see if we might be able to collect cells before they get that therapy, because sometimes we get loss of the antigen. This is our algorithm that we have in place from our adult and ALL colleagues that have devised this pathway that is in line with most other recommendations about the place of CAR T-cell therapy. So if somebody's relapsed and they have a refractory relapse, then those patients would be candidates for CAR T-cell therapy. If they're chemosensitive and just are MRD positive, they may get blinatumomab and get a transplant. Or if it's an MRD negative CR, they may go straight to a transplant. So it's always helpful to we can communicate even informally, and we can discuss these patients in our MDT to try to optimize the timing of these patients. I won't go into the details of patient fitness. It's in a document that we've shared, and we're happy to reshare it. But the reason for doing this is so that we do select the appropriate patient. So there's performance status is the most important factor. An ECOG of less than 2 is vital. Patient really has to be fit. They need to have good cardiac reserve. Their SATs have to be more than 92%. Good renal function, hepatic function, and this is similar to our eligibility criteria for allogeneic transplants, for example. There's certain other considerations about not having a severe autoimmune disease. Post-CAR T therapy, we do monitor, obviously, we monitor them in patients for at least 14 days for CRS. We won't discharge them usually before day 14, especially with our current setup. And once they're discharged till day plus 60, we will insist that they stay near the hospital. The product literature says till day 30, but we know these patients may go to rural areas where they don't have a good setup. So we would want them to be near us for at least day 60, especially because ICANS can occur later than day 28. Beyond day 60, we will see them periodically. Every couple of months, we will have to do bone marrow assessments and PET assessments, and we check for B-cell aplasia. So we do peripheral blood flow to make sure the CD19 is not detectable, and we check their immunoglobulins. Those are surrogate markers for CAR T persistence. We then need to see them, even if they're followed up somewhere else, we need to see them at least once a year for at least 15 years, and that's an FDA mandate. So that is the post-CAR T care, and that comes to the end of my presentation. One thing to say is if a patient is going to have CAR T as a bridge to an allo transplant, we would prefer that happens at our center so that we can, because we know what's happened to them, unless sometimes the patient wants to go back to their referring center and have a transplant there. But in all cases, anyone who's had CAR T cell therapy would continue to follow up for at least 15 years, inshallah. And with that, I'd like to thank you. And that's the number for the CAR T coordination office. But we have WhatsApp as well. Right. Thank you very much.
Thank you so much, Dr. Osman, and congratulations, and wish you all the best with this new program, which I believe would be very helpful to the whole region in the Middle East. I wish you all the best. I have a few questions to you. Is it possible to do the manufacturing of the CAR T in Saudi Arabia?
Right. For commercial products, the only model in place is centralized manufacturing, whether it's with BMS, Gilead, Novartis, because the QC and the QA is so stringent. Technically, these are drugs in the same way that you can't manufacture drugs in your center unless it's on a trial. These are currently manufactured centrally. There are decentralized manufacturing platforms, such as on the Miltenyi machine, but those at the moment can only be done in the context of clinical trials. So China does a lot of CAR Ts, but almost all of them are on clinical trials, and they have various models to do those. So at the moment, the only commercial approved products are centrally manufactured, and that is in Europe, North America, Australia.
Okay, well understood. Is it possible to accept non-Hodgkin's lymphoma with the age of 62? I believe.
Okay. Yeah. So we, up to 65, we say, okay, that's okay. Up 65 to 75, they were enrolled in the trials. So, we have, collected patients from like 70. We just have to be a bit more stringent. They really have to have a very good performance status, and they shouldn't have any organ dysfunction, really. This is an evolving field, so things will change. The product literature does state as a caution that the trials did not include many elderly patients. So in a certain way, we're justified. So above the age of 75, there were hardly any, very, very few patients on the trials, and there is a caution in the product literature about elderly patients. So we've borne that in mind when we've made our recommendation.
Clear. Is it possible to accept patients with the CNS disease, like mantle cell lymphoma who had the CNS disease, or this is an exclusion criteria from your side?
Okay, so at the moment for mantle cell, we don't have a Tecartus. We only have Kymriah. So we're not treating mantle cell at the moment. And so for the NHLs, certainly you can't do primary CNS lymphoma. That's the label. Things might change with emerging literature. For patients with lymphoma who may have had CNS involvement or CNS complications of lymphoma, at the time of CAR T-cell therapy, they mustn't have active CNS disease. So we might do an MRI. Certainly for ALLs, we do an MRI and we do CSF. Even for the ALLs, the ones who've had previous CNS disease, we have done CAR T-cell therapy on a patient who's had previous isolated CNS disease after consultation with an expert center. So we take some of those case by case where they really need it.
And would you accept patients from the neighboring countries like Kuwait, Iraq, UAE, or you're limited to Saudi Arabia?
So as far as these are arrangements that are made at embassy and I think ministerial level. So I think if the patient has otherwise been accepted through the embassy or through the ministerial channels and it comes to us, we will certainly accept the patient. We accept patients, and we have patients coming to us for allotransplants and for leukemia treatment. So yeah. I would have thought there should be no problem in accepting these patients for CAR T-cells there. That's the service we hope to provide.
Perfect. I think with that, we don't have any more questions. So thank you so much, Dr. Said Osman. Congratulations again. Congratulations for this work. And I hope that will expand, the CAR T program will expand to other indications like in multiple myeloma. We have now the anti-BCMA, I believe CAR T cells are approved. So yeah, this brings me to another. Would you open the CAR T program for multiple myeloma, or where is it now?
Inshallah, as soon as we have some multiple myeloma clinical trials, we hope in the next few months, we will let our colleagues know through our usual channels. But we are anticipating some trials to be open for myeloma in the coming few months, inshallah. And there are PIs for those, and people can be in direct contact with those PIs.
Perfect. Thank you so much, Dr.
Thank you.
Saeed. And then now we'll move. Thank you, Dr. Saeed, Dr. Nawal. We'll move now to the next session, which will be a satellite symposium sponsored by Sanofi, presented by Dr. Anita, who is a consultant hematologist at Kuwait Cancer Center. She will speak to us about the updates in the multiple myeloma from EHA and ASCO. Please welcome with me, Dr. Anita. The floor is yours.
Good evening to all. Thanks, Dr. Ahmed, for this kind information. And thanks to the organizers for this wonderful scientific session. And thanks to my colleague speakers. Several interesting practice-changing studies in hematological malignancies, especially multiple myeloma, were reported at the ASCO-EHA meetings 2021. I'll try to summarize the data of some of these studies in the limited time. The ASCO-EHA 2021 updates in myeloma includes the data from several trials, both in the frontline and the relapsed refractory settings with a combination of active drugs and novel agents. The ASCO here, first I'll start with the data in the frontline transplant eligible multiple myeloma patients. And this study, this was presented at the ASCO 2021, and this is an update from the 40 trial by Dr. Francesche from Italy. And this is a carfilzomib-based induction consolidation with or without autologous transplant, followed by lenalidomide or a combination of carfilzomib and lenalidomide in maintenance in high-risk patients. This is the study design of the 40 trial, and it is a 3-arms trial with 2 randomizations. The first randomization includes the combination of carfilzomib, lenalidomide, dexamethasone without transplant given for 12 cycles. And the other 2 arms include carfilzomib with cyclodexa, which is the KCD, and the KRD with transplant. The second randomization is between the lenalidomide alone and the doublet carfilzomib and lenalidomide combination. The key goals of this analysis were the progression-free survival and MRD negativity. The progression-free survival data can be seen in the graphs, and the median follow-up from the random 1 at 51 months showed a clear benefit of improved progression-free survival in the KRD with the transplant arm. When compared to the KRD without transplant versus the KCD with transplant in all patients and in all risk subgroups. We also see the MRD benefit here for the KRD transplant in the pre-maintenance. And there is a very high 1-year sustained MRD negativity rates with the KRD transplant group. We also understand from this study that the choice of induction treatment matters significantly, and using the KCD induction with transplant had a worse outcome than no transplant at all. Now, this is the progression-free risk or progression-free survival of the risk groups at randomization 2, which shows the doublet carfilzomib lenalidomide improved the progression-free survival in multiple myeloma with all high-risk characteristics except the amplification of 1q. So in conclusion, the KRD transplant significantly prolonged the progression-free survival and increased the rate of 1-year sustained MRD negativity when compared to the KRD without transplant versus the KCD group. And the doublet carfilzomib lenalidomide significantly prolonged the progression-free survival from start of maintenance versus the lenalidomide arm alone. So this is another trial focusing on the high-risk myeloma population is the Optimum Mgta trial from the United Kingdom by Dr. Kaiser. And in this trial, they have attempted to put all the active drugs together. So this is the study design of the trial, and patients were in the ultra high-risk group, which means more than 2 high-risk lesions as seen. I think there is some problem with my slides.
Yeah, if you can go back, Dr. Anita, I think.
Yeah, this is okay. Yeah. So this is the trial design of the Optimum Mgta study design of the Optimum Mgta trial. And we can see here that the patients belong to the ultra high risk group, and they were given initially 2 cycles of the standard of care with VTD or with BCD as a bridging till the risk stratification. This was followed by an induction with a combination of DARA with a quadruplet regimen. This was followed by an augmented stem cell transplant, followed by 2 consolidations. The first consolidation was DARA with a triplet regimen, and followed by the second consolidation with DARA with a bortezomib lenalidomide, followed by maintenance DARA with lenalidomide. The overall response rate and the MRD results are very impressive, with the overall response of 99% with more of VGPR and MRD negativity of 82% at post-transplant. So we can understand that the DARA in combination with this quadruplet regimen along with augmented autologous transplant induced deep remissions in patients with the ultra high risk multiple myeloma group. Now we'll move on to the next slide, which is the Cassiopeia Part 2 trial by Dr. Philippe Morio, presented at the ASCO EHA 2021. This shows the daratumumab maintenance versus observation in patients with newly diagnosed multiple myeloma treated with the bortezomib, thalidomide, and dexamethasone with or without daratumumab and stem cell transplant. The part 1 of the Cassiopeia study involves the induction with VTD with or without DARA, followed by transplant and consolidation. And DARA VTD was approved as a frontline prior to transplant. Now, in the part 2 randomization, this was between the DARA maintenance versus observation. And Professor Morio could show that DARA maintenance improved the progression-free survival from second randomization versus observation. And the interesting part is that this improved progression-free survival was seen in patients treated with VTD induction and consolidation rather than the DARA in the upfront. Next, we have the updated interim analysis of the Gmmg concept trial investigating the combination of isatuximab, carfilzomib, lenalidomide, and dexamethasone in frontline treatment of high-risk multiple myeloma patients. This study is evaluated in patients with high-risk newly diagnosed multiple myeloma with the baseline characteristics of high-risk features. And we can see that the majority of the patient were having the deletion 17p and gain 1q21, which carries a bad prognosis. These patients, they were treated with the induction with isatuximab KRD for 6 cycles, followed by transplant in the transplant eligible patients, followed by consolidation and maintenance. This study involves both the transplant eligible and the transplant ineligible patients. And this study has a convincing data on the benefit of the isatuximab KRD, which shows that this updated interim analysis of the first 50 patients treated with the combination in this trial showed an overall response rate of 100% and an encouraging progression-free survival rates at 12 and 24 months. The overall response rate was 100%. Not only that, there was an MRD negativity rate of around 61%. So this shows that this combination may be durable, especially in the high-risk population. Next, we'll focus on the frontline treatment of transplant ineligible population. And we have the overall survival results with daratumumab, lenalidomide dexamethasone versus lenalidomide dexa in newly diagnosed multiple myeloma. This is a phase 3 Maya study by Professor Facon and colleagues, and this was a late-breaking abstract in the EHA 2021. So here we have the 5-year follow-up of the study of DARA lenalidomide dexamethasone versus len-dex. And in this, the key eligibility criteria was transplant ineligible patients newly diagnosed with the ECOG performance score of 0 to 2 and good renal function status. And the primary endpoint of the study was a progression-free survival with key secondary endpoints of overall survival, progression-free survival, to overall response rate with CR and MRD negativity. The MRD assessment by NGS. The median duration of the study treatment was 47.5 months in the DRD arm and 22.6 months in the RD arm. The DRD combination induced a deeper response and also demonstrated a significant progression-free survival benefit, and as well as an overall survival benefit with a 32% reduction in the risk of death. The overall overall survival benefit was consistent across the patient subgroups. So this is a very impressive overall response rate, and the progression-free survival of 5 years is close to 16 months in the elderly population. And so after almost 5 years, the benefit was, there was a significant benefit in these patients. And so giving the best treatment in elderly population gives them the chance to get the best results. Now we will move on to the relapsed refractory setting of the myeloma patients. And here we have the updates from the ICARIA multiple myeloma, which is a phase 3 study of isatuximab plus pomalidomide and dexamethasone versus pomalidomide dexamethasone alone in relapsed refractory multiple myeloma. So we have the baseline characteristics in these patients where they were previously treated with lenalidomide and proteasome inhibitors, and more than 90% of these patients were refractory to both lenalidomide and proteasome inhibitor. The median progression-free survival was 11.1 months in the isatuximab pomalidomide dexamethasone arm, when compared to 5.8 in the pomalidomide dexamethasone arm. And the median of overall survival was also better with the combination of isatuximab with 24.6 months. So after around 3 years, the isatuximab pomalidomide dexa continued to improve progression-free survival and depth of response consistent with the primary analysis. And also significant improvement in the time to next treatment and PFS2. DARA monotherapy appears less effective following the isatuximab pomalidomide dexa. However, there was no difference in response when DARA was given as combination therapy. Now, regarding the overall survival benefit, an approximately 7-month improvement in the median overall survival was seen in the isatuximab pomalidomide dexa arm. So addition of isatuximab to PomDex significantly improves the progression-free survival in patients with relapsed refractory multiple myeloma, and isatuximab is a new treatment option, particularly for patients who became refractory to lenalidomide and a proteasome inhibitor. Now we have in the next relapsed refractory settings, the STORM study, which is the multi-center open label phase 2 study of the combination of selinexor with carfilzomib and dexamethasone in relapsed refractory patients. And selinexor with carfilzomib showed a synergistic anti-tumor activity. The patients in the study were heavily pre-treated with more than 6 lines of treatment, 6 lines of therapy. And they had received prior bortezomib, lenalidomide, pomalidomide, DARA, and most of them were quadruple refractory. And in this heavily pretreated patients, the weekly selinexor with carfilzomib dexa is highly effective with deep response. The overall response rate was 78% as seen in this slides, and consists more of a VGPR and a PR. In patients who have received prior DARA, the overall response percentage was 67 with more of VGPR. All adverse events can be managed with appropriate supportive care and dose modifications. A significant benefit was observed in patients treated with DARA. Now we have the updates, which are a breakthrough in the treatment of relapsed refractory multiple myeloma patients, and these are the bispecific monoclonal antibodies. So first we have the teclistamab, which is BCMA and a CD3 bispecific antibody, and it is presented in the phase 1 Majestic One study. In the key eligibility criteria, including adult patients with patients with measurable multiple myeloma with hemoglobin of more than 8, platelets more than 75, ANC more than 1. They have excluded patients who were previously treated with a BCMA targeted therapy. So at the recommended phase 2 dose, teclistamab showed a promising efficacy with durable responses that deepened over time. FDA has granted the breakthrough therapy designation to this. The next we have the phase 1 monumental study. This is an updated data on the first-in-class talquetamab. In this study, patients previously treated with BCMA targeted therapy were included. And the recommended phase 2 dose in this study is 405 microgram per kg subcutaneously. And CRS was generally noted but confined to step up and the first full dose. And the CRS was limited to grade 1 and 2 in all patients, with the exception of one patient with a grade 3 CRS. The overall response rate was 66.7% with more of VGPR. This is the only investigational bispecific antibody directed against the novel target GPRC5D and also CD3. Then the last we have the elranatamab, and included in the magnetism study. This also has a promising efficacy, and we can see many stringent CRs and VGPRs from the graph with MRD negativity. The CRS was generally confined again to the CRS are the 3 out of here in the box is the 3 out of the 4 patients with the BCMA targeted therapy who were exposed to the BCMA targeted therapy. 2 had VGPR and 1 had astringency. So with this promising data on a variety of drug combinations in myeloma, I thank all of you. Hope we have very good treatment combinations for all our patients, especially the relapsed refractory patients. Thank you.
Thank you, Dr. Anita, for this excellent presentation on the update on multiple myeloma. I think the immunotherapy is also has another arena, the multiple myeloma treatment. Now we have the antibody drug conjugate as well as the bispecific T-cell engager in treating multiple myeloma, in addition to the CAR-T cell therapy presented by Dr. Nawal as well. This is very encouraging for all of us and for all our patients. Thank you so much. I think the field is moving toward including monoclonal antibodies in the frontline setting of treatment of multiple myeloma. What do you think of that?
Dr. Ahmed, are you asking to me?
Yes. What do you think of like including now? I think the field is moving toward including monoclonal antibodies in the frontline setting of multiple myeloma, especially for high-risk population.
Sure, doctor. So I think like with this novel treatment and novel agents and with accessibility of this monoclonal antibodies, definitely we have to try all these combinations because as the new therapies are evolving, we do find more patients in the relapse setting. So I think especially the first in class, the monoclonal antibody was the Narsoplymab, which we have started to use it in our elderly patients. As I have shown in the study, the Maya study, we have started using it in elderly patients with Narsoplymab with the combination of lenalidomide and dexamethasone. And then we have the next upcoming, the isatuximab. As you know, in our center in Kuwait, we have not yet started to use it, but I think it gives a very promising strategy to use in our patients. And that too, for patients who had already have received DARA, they can also be they can also be started on isatuximab.
Excellent. There is a question to you, Dr. Anita. Do you think these new combination would replace the need for auto transplant?
That's a very good question. But most of the trials, what I had presented today, it is in high-risk patients who are transplant eligible. But definitely in ineligible, but in patients who are transplant eligible, definitely transplant plays a major role, because we all know that autologous transplant itself plays an important role in the remission status of the patients. So I think I do give these combinations, but definitely, if feasible, transplant, that is the two upfront transplant or a delayed transplant is a must in all my patients.
Thank you so much, Dr. Anita. And I think still the auto transplant is a standard of care for our multiple myeloma patients. And there are ongoing trials to assess the need for auto transplant and testing the need for auto versus CAR-T cell program for multiple myeloma in the frontline setting. So I think until we have these data, we will see whether auto transplant would be needed or the CAR-T would replace it. Thank you so much, Dr. Anita. And then now we'll move to the next speaker, Dr. Biniam Osman, who's a consultant hematology and bone marrow transplanter at King Faisal Specialist Hospital in Jeddah. He will be speaking to us about the updates and the stem cell transplantation from ASCO and EHA. Welcome, Dr. Osman.
Assalamu alaikum jamian. Bismillah ar-Rahman ar-Rahim. I hope you can see my slides and hear me. Dr. Ahmed, if you can hear me, I'd like to thank you, Dr. Amal and SSBD for giving me this opportunity to present the abstracts, which I thought were standout ones from ASCO and EHA this year. And the advantage of speaking at the end is that even if you go beyond your allocated time, I hope Dr. Ahmed will not stop me, because there are many exciting drugs and therapies that we need to discuss. So I'd like to discuss these trials, and if time allows, I would discuss the exciting new drugs as well. So moving on to the first study, this is a phase 3 REACH2 study. This is looking at the efficacy and safety of ruxolitinib in patients with steroid refractory acute GVHD. But this is after crossover. So the phase 3 REACH2 study was already reported. And we know ruxolitinib is already FDA approved for steroid refractory acute GVHD. In this trial, about 300 patients were randomized 1-to-1 between ruxolitinib 10 mg BID and best available therapy. And the overall response rate at day 28 is the primary endpoint. But patients were allowed to an optional crossover from best available therapy to ruxolitinib. So there was a reported overall response rate of 62% in the ruxolitinib arm at day 28, as against 39% with the best available therapy. And this 62% included 34% CR. The overall response at day 56 was durable as well. So from 62%, it did drop to about 40%, but still was much better than the comparative arm. Now we will look at those patients who actually crossed over from the best available therapy to the ruxolitinib arm. And you can see that in the right-hand side column, 49 patients crossed over from BAT to Rux, and their overall response rate improved from 39% to 67%, similar to the ruxolitinib arm. And similarly, the durable overall response at 56 days also improved from 21 to 42 days, comparable to the ruxolitinib arm. And the side effects were quite manageable. So the conclusion of the study was that ruxolitinib led to high response rates in patients who crossed over from the BAT to Rux arm. Overall response rate and durable ORR were consistent with those seen with the Rux arm, and no new safety signals were seen in these crossover patients. So this is a practice-changing study, and it supports the use of ruxolitinib in patients with steroid refractory acute GVHD who failed treatment with other systemic therapies. Moving on to the second trial, this is ibrutinib along with corticosteroids versus placebo and corticosteroids in patients with new onset chronic GVHD. This is the phase 3 randomized trial called Integrate. So we know that ibrutinib has demonstrated some efficacy and safety in chronic GVHD. And in US, this is currently the only therapy for adults with chronic GVHD after failure of more than one line of systemic therapy that is approved. And this was a multi-center study involving 31 international sites. There were about 100 patients randomized to both arms, the ibrutinib prednisolone arm and the placebo prednisolone arm. But essentially, this is a negative study. Response at 48 weeks was no different between the ibrutinib and the placebo arm. It was 41% versus 37%, with a p-value which is insignificant. When you look at the secondary endpoints, there is some trend towards benefit in the ibrutinib arm, like 16 months versus 10 months, 15 months versus 8 months. And the number of patients whom the steroids were withdrawn were 48% versus 39%, and the withdrawal of immunosuppressants in 38% versus 28%, but none of it was statistically significant. And the median overall survival was not reached in both arms. Grade 3 serious adverse events were similar, and discontinuation of therapy due to adverse events were also similar, despite ibrutinib being one of the arms. So this is the event-free survival curve. The yellow curve is ibrutinib prednisolone. Although there is a minor advantage, there is no statistical significance for this EFS. So in conclusion, this randomized placebo-controlled trial was a negative study, and the primary endpoint did not meet statistical significance. But there was some numerical trends which benefited the ibrutinib arm, and therefore ibrutinib may have value in some previously untreated patients with chronic GVHD. So this study looked at prophylactic or preemptive use of TKIs post-allogeneic transplantation in Philadelphia positive ALL, and this is a sub-analysis of Gitmo Philadelphia positive ALL study. Preemptive approach was defined as starting the TKI at the first MRD positivity following stem cell transplant. And prophylactic TKI was defined as starting TKI post-allotransplant while the patients are still MRD negative. 441 adult patients were involved who were all Philadelphia positive. They were all treated in the induction phase with TKIs and chemotherapy, and they underwent allotransplant between 2005 and 2017. MRD was monitored monthly for the first 6 months post-allotransplant and then every 2 months. If you look at this table on the right-hand side, TKI was started preemptively in 71% of the patients and prophylactically in 29% of the patients. So the median TKI start time point was 2.97 months in the prophylactic arm and 4.37 months in the preemptive arm. If you look at the 5-year overall survival and 5-year disease-free survival, you can see that the prophylactic approach was much better than the preemptive approach, and it was clinically statistically significant as well. Looking at the graph on the left-hand side, the blue curve is prophylactic patients who had MRD negativity prior to allotransplant. And the yellow curve is prophylactic patients who had MRD positivity prior to transplant. So these two curves look the same, whether they were MRD positive or negative. The prophylactic approach seems to benefit both. However, the preemptive approach, whether they were MRD negative prior to transplant, they did as badly as the MRD negative group, MRD positive group. So in conclusion, this was a retrospective study, so you have to be cautious. Prophylactic use of TKIs post-allotransplant is an optimal maintenance strategy. And regardless of the MRD status pre-allotransplant, higher probability of disease-free survival. This is a study by the Acute Leukemia Working Party of the EBMT, looking at 2 different conditioning regimens in AML who are in first CR, fludarabine and TBI 8 guy versus fludarabine and treosulfan. So we know in AML patients who are over the age of 40, fludarabine and reduced dose TBI, which is 8 guy, has yielded favorable long-term outcomes. So cumulative incidence of relapse was 30% and non-relapse mortality was 13%. But more and more people seem to be using, in Europe at least, fludarabine treosulfan due to its low non-relapse mortality. And there is no direct comparison of these 2 conditioning regimens, but this retrospective study looked at the anti-leukemic activity and the safety of flu TBI and FT. All the patients were received either matched sibling donor or 10 out of 10 MUD, and using the propensity score matching, 115 patients were matched between the 2 arms. If you look at the results, the cumulative incidence of relapse was clearly lower in the flu TBI arm at 18% versus 34% in the flu treosulfan arm. However, the non-relapse mortality was much higher in the flu TBI arm at 16.8% versus 5.3%. The rest of the parameters, the GVHD, acute and chronic, 2-year leukemia-free survival, 2-year overall survival, they were all similar between the two arms, and there was no statistical difference. In the flu TBI arm, the main cause of death was infection at 31%, followed by AML at 26%. And in the flu treosulfan arm, the main cause of death was AML relapse, which is 45%, and GVHD 21%. So in conclusion, outcomes in leukemia-free survival, overall survival, and GVHD-free, relapse-free survival did not differ between flu TBI and flu treosulfan. Relapse was clearly lower with flu TBI, but non-relapse mortality was higher with flu TBI. So flu TBI seems to be a more intense conditioning regimen. This is an interesting study from Japan. Autologous versus allogeneic transplant for peripheral T-cell lymphoma not otherwise specified, and angioimmunoblastic T-cell lymphoma failing first-line therapy. We know that salvage chemotherapy followed by autotransplant or allotransplant is a treatment of choice for relapse refractory patients with PTCL-NOS and AITL, but there is no consensus on which type of transplant should be applied for such. So this is a retrospective analysis from the Japanese registry. 762 patients, out of which 449 had PTCL-NOS and 313 had AITL. Autotransplant was done in 450 patients and 312 underwent allotransplant upfront. Looking at the results, if you look at the first two lines, the chemosensitive patients, 4-year overall survival, and chemo-refractory patients, 4-year overall survival, seems to favor allotransplant, although there is not much difference between autotransplant and allotransplant 4-year overall survival in the chemosensitive arm. When it comes to progression-free survival, both the chemosensitive patients and chemorefractory patients benefited more from allotransplant versus the autotransplant. However, the non-relapse mortality clearly was higher in both sets of patients in the allo group. On these graphs, black lines represent the allotransplant group and the red curve represent the autotransplant group. And on multivariate analysis, it was shown that the allotransplant seemed to do better both in progression-free survival and overall survival. So the conclusion is that despite having more unfavorable factors, patients undergoing allotransplant for PTCL-NOS and AITL failing first-line therapy can result in comparable survival outcomes compared with autotransplant. And so patients with relapsed, sensitive, and primary refractory disease may be good candidates for allotransplant if suitable donor is available. This is a phase 2 clinical trial of allogeneic stem cell transplant for high-risk myeloma, followed by maintenance with bortezomib and lenalidomide. So it's an updated analysis of the EMN AlloRic 2010 trial. RIC-Allo has been the preferred conditioning for myeloma due to the low non-relapse mortality, but we know that relapses are common. There is a small group of people who are cured with this approach as well. Another thing that we know is the use of bortezomib within the conditioning regimen was demonstrated to be safe, and it allowed to obtain a high response rate after RIC-Allo in a previous phase 1 trial. So in this trial, they attempted to decrease the risk of relapse further by adding maintenance with bortezomib and lenalidomide following reduced intensity allograft. It was a multi-center phase 2 trial, and the reduced intensity conditioning included bortezomib, fludarabine, and melphalan. And the GVHD prophylaxis was based on bortezomib, methotrexate, and tacrolimus. For maintenance therapy, all patients received bortezomib starting from day plus 70 and lenalidomide starting from day plus 180, and some intensification of therapy based on day 100 disease status. So all the 24 patients in the trial had received treatment with proteasome inhibitors and immunomodulatory drugs, and 87% had received a previous autotransplant. If we look at this table, grade 3 to 4 acute GVHD at 100 days was 21%. Moderate to severe chronic GVHD at 1 year was 18%. Non-relapse mortality at 1 year was 21%. Relapse at 1 year was 13.6%. Event-free survival at 3 years, 42%, and overall survival at 3 years, 74%. And if you look at this graph, you can see at 60 months, there are 40% of people who are still in event-free survival, and about 60% of people in having overall survival. So it's not a, reduced intensity allograft does have a role in myeloma. So combination of allotransplant with novel drugs could improve the efficacy of the procedure in multiple myeloma. Maintenance treatment with lenalidomide and bortezomib leads to a low risk of relapse. Although the risk of chronic GVHD did not increase, lenalidomide was stopped in a significant proportion of patients. It's a very interesting scoring system developed by the Korean team. It's an integrative scoring system based on quantitative dynamics of MRD for relapse prediction in patients with ALL. We know that cumulative incidence of relapse post-allo transplant in ALL is influenced by MRD assessment at different time points and other variables such as T-cell lineage, remission status after induction therapy, and remission status pre-transplant. So what they did was they took 1,400 patients who underwent HLA-matched sibling transplant or haploidentical transplantation. And the first cohort was the retrospective training group, which included 651 patients. And they found the factors that were related to incidence of relapse, identified it using a multivariate Cox model. Now, once these factors were identified, they validated it using a prospective group of 765 patients. If you look at the table on the left-hand side here, people who had low score or low risk group had a 3-year risk of relapse of only 10% in the training cohort and 7% the validation, which is almost similar. Intermediate risk group had between 19 to 24% risk of relapse at 1 year, at 3 years, sorry. High risk group had between 45 and 47% risk of relapse at 3 years, and very high risk group had 90 to 100% risk of relapse. So this scoring system allows us to separate the curves beautifully, and we can in future predict who are the patients who are likely to relapse and can we do anything about it. Moving on to the newer drugs that were studied. The first trial I want to discuss is the Equate study, which looked at itolizumab, which is a novel targeted anti-CD6 therapy for newly diagnosed acute GVHD. CD6 ALCAM pathway is central to immune inflammation in acute GVHD, and CD6 is a co-stimulatory receptor expressed on the T cells. So by using itolizumab, we can reduce the number of CD6 receptors on the T cells and convert them from pathogenic cells to non-pathogenic T effector cells. In the Equate trial, which is a phase 1b/2 trial, open label, there was a dose escalation part and a cohort expansion part. In the original study, it was grade 3 to 4 GVHD patients, and the cohort expansion had grade 2 GVHD patients as well. So if you look at all the dosing levels at 24 hours, you can see that this is a CD6 percentage at baseline, and all of them reduce the CD6 percentage significantly, all doses. And day 15, you can see the same. The higher 2 doses kept the CD6 percentage at a low level, which was maintained at day 29 as well. Now, this is the efficacy responses at day 15, overall response rate of 75%. And in those people who received more than 2 doses, the overall response rate was 92%. At day 29, overall response rate were 70% and 92%. So it was sustained response until day 29. The response at month 6 or day 169, can see an overall response rate of 60%. And in those people who received more than 2 doses, it was 72%. Non-relapse mortality, recurrent acute GVHD and chronic GVHD were all persistently low. By day 29, the use of systemic steroids had come down nicely, and this reduction was maintained throughout the study. Most adverse events were mild to moderate in severity and could be managed. So in conclusion, first-line itolizumab anti-CD6 treatment resulted in rapid and durable response in high-risk acute GVHD, and this is one drug we have to watch out for in the future. Moving on to the next drug called belumosudil for chronic GVHD after 2 or more prior lines of therapy. This is a ROCK-STAR study. ROCK is an intracellular integrator of pro-fibrotic signals. So ROCK2, so basically this drug belumosudil is a selective ROCK2 inhibitor. And by inhibiting ROCK2, we can downregulate the pro-inflammatory T helper cells and increase the T reg cells. It's an oral agent, and this is the pivotal trial design, randomization to 2 doses, 200 milligram once daily or 200 milligram twice daily. Primary endpoints was overall response rate. You can see in both those groups, the overall response rate were in excess of 70%. And complete responses were seen in all the organ systems, whether it is GI, mouth, esophagus, eyes, skin, liver, lungs. And the bars in gray represent complete response. So significant response to this agent. 44% of patients have remained on belumosudil therapy for more than 1 year. And the median duration of response was 54 weeks, which is more than a year. Corticosteroids were discontinued in 21% of patients. The main side effects, there were significant side effects, well in excess of 20%, fatigue, diarrhea, nausea, cough, upper respiratory tract infections, dyspnea, and so on. 14 patients died during the study. 8 were due to adverse events, and 2 were possibly related to belumosudil. And 6 died during the long-term follow-up. So in conclusion, belumosudil was well tolerated at both doses, resulted in high overall response rates across key subgroups meeting the primary endpoint. Responses were durable and clinically meaningful, irrespective of patient and chronic GVHD characteristics and organ involvement. The next drug is Narsoplymab, which is a monoclonal antibody, which is used in adult patients with high-risk transplant-associated TMA, thrombotic microangiopathy. This is the complement pathway. Endothelial tissue injury activates the complement pathway. You have the classical pathway, the alternate pathway, and the lectin pathway. And this can lead to inflammation, hypercoagulation, and TMA. Narsoplymab is a monoclonal antibody which binds to the MASP2 or Mannan binding lectin-associated serine protease 2 and blocks only the lectin pathway and leaves alone the classical and alternate pathway. This study was a single-arm open-label study of high-risk transplant-related TMA patients. And Narsoplymab was given intravenously once weekly for 4 or 8 weeks with a 6-week follow-up period. And in all treated patients, the response rate was 61%. And patients who had a treatment as per protocol, which means more than 4 weeks of dosing, had an overall response rate of 74%. There was improvements noted in kidney function, neurological function, gastrointestinal systems. So generally, all the organ systems improved. 6 patients died during the core study period. On the left-hand side is a platelet graph. So the time to hematological response was as early as 7 days. And this was sustained. As you can see, the platelets are going up even at study week 13. 100-day survival following the HSCT-TMA diagnosis. All treated patients' survival was 68%. Patients treated as per protocol, 83%. And those who responded completely, the survival was 94%. So Narsoplymab has been given a breakthrough therapy designation from FDA and an orphan drug designation from FDA and from EMA. So we may be able to use this drug sooner rather than later. This is a phase 1 trial of the hedgehog pathway inhibitor Glasdegib, which has been used in AML patients and is under clinical trial in the AML setting. But this was used in patients with refractory sclerotic chronic GVHD at low doses in continuous 28-day cycles because it's an oral medication. This led to durable responses in 1/3 of the patients. So that might be a useful drug in future for refractory sclerotic chronic GVHD. This is another exciting drug, Mgta 145, which was used along with Plerixafor for single-day mobilization of stem cells for autologous stem cell transplantation in multiple myeloma. So it's a phase 2 study. We know that Plerixafor disrupts CXCR4, which anchors the stem cells to the bone marrow stromal cells. This new drug, Mgta 145, it binds to CXCR2 on neutrophils, which triggers release of factors that stimulate the stem cells to easily migrate out of the niche in the bone marrow into the circulation. So together, these two drugs release a large number of functional stem cells from the bone marrow. So this was a phase 2 study in multiple myeloma patients with the purpose of doing same-day apheresis. Plerixafor was given subcutaneously. Following that, 2 hours later, the Mgta 145 was given intravenously over 3 to 10 minutes, and apheresis was started within 30 minutes. The primary endpoint was to collect more than 2 million CD34 cells in a maximum of 2 days of apheresis. And secondary endpoints were collecting more than 4 million and more than 6 million stem cells in 2 apheresis sessions, and the time for engraftment. As you can see, all the patients collected the 2 million stem cells in 2 days' time. The induction therapy used in all these patients included Revlimid. So it was VRD in 7 patients and Dara VRD in 3 patients. Median lenalidomide exposure was 6 cycles. Total stem cell yield was 7.1. Day 1 yield median was 5.4. Yield per apheresis session was 4. 90% of the patients had the 2 million cells collected in the first day. Mgta 145 was very well tolerated, and the side effects were resolved without any intervention. Looking at the engraftment as well, all the patients who underwent collection with this drug engrafted on time. And this is the last of the drugs I want to discuss. This is a phase 1 study of JSP191, which is an anti-CD117 monoclonal antibody, which was used with non-myeloablative conditioning in older adults with MRD positive MDS/AML undergoing allotransplant. So basically, this JSP191 is a monoclonal antibody which inhibits the stem cell factor binding to CD117, the c-KIT. And what they did was they added the drug to a standard non-myeloablative conditioning of 2-guy TBI and fludarabine. And they were hoping to deplete the MRD in the older adults with high-risk MDS-AML. All the subjects are still on trial. There was no infusion-related toxicities or serious adverse events. All the subjects engrafted and showed more than 94% donor myeloid chimerism on day 28. There were 3 evaluable subjects with day plus 90. They all showed total chimerism and MRD elimination. So these are the patients enrolled. The patients who had completed 90 days had MRD negativity. And there was another patient who had MRD negativity. The others haven't reached the day 90 yet. So in conclusion, these early results are the first to demonstrate that this monoclonal antibody JSP191 with TBI and fludarabine is safe, well tolerated, and capable of clearing MDS, AML, MRD in older adults undergoing a non-myeloablative transplant. With that, I have come to the end of my talk. Thank you for listening.
Thank you so much, Dr. Osman. That was an impressive overview of the transplant updates from the EHA and ASCO. Have you seen any data on the c-KIT inhibitor on patients with c-KIT mutated, like mastocytosis, let's say, or core binding factor acute myeloid leukemia?
Unfortunately, no, I haven't. I didn't look into detail, but this was the abstract presented this in ASCO. But I don't know if this has been used in the other setting, like you mentioned, the AML setting. So I'll have to look into that. But it looks impressive. I mean, AML has been a difficult disease to treat, and if this can be if this can clear the MRD in older patients, then I think it will come into clinical trials in the AML induction setting as well.
Thank you so much, Dr. Osman. I think there are no questions here. Just I would like to mention that the webinar is recorded and it will be available through the SSBD YouTube channel as well as Twitter account. I would like to thank all our speakers for today's lectures, and also would like to thank the sponsor, Sanofi, for their kind sponsorship, and the Dr. Amel Bihani, who went through the ASCO EHA webinar series. And finally, this is the last day of our webinar. And if you want to look into the previous ones, all are available on the SSBD YouTube channel. With that, we will conclude, and thank you so much, and see you soon in the future meeting.
Thank you very much, Dr. Ahmed and Dr. Amal, for arranging this meeting and for SSBD. And thanks for everyone who attended.
Thank you.
Thank you. Thank you all.
Thank you very much.